Hey Eric, how you doing?
Not too bad. What's going on today?
Much, not too much. I was just sifting through the archives.
It's a deep dive.
Yeah, no, just a couple of gyms videos out there on sacroiliac joints. I'll put up and I'll send out, I'll put on the page for them to kind of review. I mean, it's a nice prep work. It's more innominate rotations where, I mean, certainly you'll get into the coursework more the sacral torsions and treating of those as well, where he doesn't kind of elaborate on that a bit, but I'll send out some of the other ones to him. Like, I might get that out.
Sounds good. Yeah, so I mean, I think today I was just going to continue through the kind of the introduction PowerPoint
Yeah.
stuff. We didn't get through as much of as I thought we were going to last week, which is
Mhm.
okay. Kind of don't mind where we ended up, but certainly want to try and get to the kind of primary lumbar pathologies today. But wanted to open up to you guys first, see if you had any specific questions, anything you want answered before we get rolling. Nothing?
I got a question.
All right, Joey, let's hear it.
So, and so with a pelvic rotation, if you have like an anteriorly rotated pelvis, could can that be coming from like a sling dysfunction, like the posterior sling?
Um, it's less likely. You're talking about the posterolateral sling, so you're talking about the glutes and the lats. Is that
And
the
the
one you're
lat,
talking about?
yeah, yeah.
Yeah. I would think it's less likely, just because of the attachment points. They're more oblique as far as the orientation of those fibers. They're really going to kind of crisscross the sacroiliac joint. So what it's going to do for you more is it's going to actually compress the joint together. That the rotations need more of a vertical orientation for me, right? So something that's kind of going in this direction. So that's why we look at things like the deep longitudinal sling. So that's going to be some of the long thoracic paraspinals, in particular the iliacostalis. You can get it from the hamstrings, in particular the biceps femoris, because of the attachment point to the ischial tuberosity. And you can get it from the quadratus lumborum, in my opinion, as well. So those have more of that vertical vector as opposed to that oblique vector. Why do you ask? Did you see somebody that you think might have been having such a thing?
Yeah, I have a patient with anterior pelvic pain. Um,
Hmm.
and he has an anterior rotation of his pelvis, which I think is driving most of it. And started doing some stuff with his thoracic spine, and that's been beneficial. And then Tanner had me look at his C6, and so he had a C6 segmental facilitation, which was changing like his lat and then down into his posterior sling, which was kind of throwing off some of the side too. But that's what I've been dealing with. So I was just curious what you have seen as far as sling dysfunctions.
Yeah, I mean, the problem with it is that if you have a facilitation of the lats, right, from a C6 issue, what it's more likely to do as far as the sling is it's going to inhibit the other half, right? So the glutes then are probably going to be inhibited on the opposite side, um, as opposed to it being something that's really going to kind of throw off the that position of the innominate. Now, could it potentially do it? Maybe. I mean, I would say it's not going to be one of the situations that I would look at as a potential causative factor for an innominate rotation. Um, but it's not that it's not likely affecting the joint because it probably is because again, it's one of the more dynamic stabilizers of the pelvis in and of itself, being the interconnection with the glutes themselves. So I don't know. What about you, Dave? Have you seen that consistently or ever?
I have, I just need a little more. Can you give me a little more detail on the individual? Because kind of when you start talking about slings, it slings overlap different things that you're going to see. So, you can play with that as a stabilizing structure, but are you missing other things that are involved in it? Like, okay, your posterior sling, what's going on with the hamstring? Do you have an innominate that is that is not stabilizing properly as you do this? Is it rotated and stuck? I think I see more myofascially stuck SI joint problems where you have hypertonicity and guarding more than I see articular restrictions in a sense. That kind of comes from what I've seen in the pelvic world. So it's, with the slings, I do consider slings as I look at things, and especially gross movement and efficiency of movement. But I would probably think that the sling or the motor pattern would be the driver, not the sling being the primary for the dysfunction. So I'm not sure if that helps in what we're discussing.
Yeah, no, it does. I think it's just one of the contributing factors. He has absolutely like no ability to hip hinge. And his glutes are super inhibited, and he has like poor hamstring tone too. And so he's just kind of in that like super lordotic positioning.
Which you probably have is a mix of he's probably has high hamstring tone, but poor strength and force output.
Yes, yeah, his force was trash.
Yeah, so yeah, I'm worried that in that case where you're going to see that with facilitation. So then the question begs, okay, is it an adaptive strategy? What is he stabilizing the hamstring for? Is it just he's built this as his innate pattern, and this is the pattern that he grooves, versus, is he stabilizing for something? A guy, I wouldn't imagine he's trying to use both hamstrings to stabilize an SI joint. So I think that's less likely. Or he just developed this as his neural pattern. Has it developed because he's got a hyperlordosis? So the hamstrings are always hypertonic, and it's because that's been his pattern because it was anterior sacral tilt. Because you a natural, again, more anteriorly tilted sacrum.
Mm-hmm.
So part of it is deciding how much of him is biomechanically preset and he's moving around it, how much is adaptive change.
And you said
How? Oh,
you
sorry.
said his sorry, you said his pain is anterior on the pelvis.
Like just above his pubic bone.
Hmm. That's a weird
It's
spot.
Yeah, I was gonna say hopefully Courtney will jump in too because he's here for pelvic pain, but
Mhm.
Courtney's dying to jump in and
I'm sure.
fill us in on
Um,
what's going on. It's dying.
but yeah, I'm just looking at like mechanically. I mean, he has a bunch of mechanical dysfunction going on too. But I think most of his pain is psychosomatic. As far as the anterior pelvic pain that he's having, just because he's a interesting individual, to put it nicely. And but looking at like the mechanics of it, we had just started looking at his posterior sling too, just to see if that would help with some of the hip hinging motion to like get him out of that anterior pelvic positioning and try and rotate that back. Because if I manually rotate it back, it does decrease some of his like pain and pressure in the anterior side of his like lower abdominals. Um,
And you're
so
doing
it's
that
just
on one side, right? That's just a unilateral thing.
yeah, so it's his left um SI more so than his right, but he's pretty, I mean, hyperlordotic bilaterally.
Okay. Yeah, I mean, well, based on where the pain is, I would almost look at that anterolateral sling more. So if you're dealing with a situation where you have kind of that anterior rotation. So you've got one side that's kind of tilted forward. Well, that's going to create some obliquity and some poor length tension relationships between some of that abdominal musculature. And so the other half of that is going to be the adductors. That kind of, you come down in the abdominals and it attaches to the pubic bone, and then it kind of continues contralaterally to the opposite leg, going down as the contralateral adductors, adductors, right? So that's a situation where you could be like, well, are the abdominals inhibited because of alterations to the adductor tone on the contralateral side, which could be affected by, either an SI joint issue or a lumbar issue, or maybe even a hip
Mhm.
issue. You know what I mean? So
Okay.
so that's another possibility because that's more directly correlated than the posterior sling would be if you're dealing with anterior pain. So one thing that I always check for when I have somebody that has that lower abdominal pain, is have them do like kind of a half sit up, kind of like a crunch, basically. So
Mhm.
if they get into like a hook lying position, squeeze their heels together, and that's going to take the glutes out of the equation and the hip flexors. And then just have them curl up. If that reproduces the pain, um, then you're probably looking at an abdominal muscle issue. right? And so that could be more similar to a hernia. The other thing that you have to do then is I just usually use two fists like this, and I put it in between both their knees and have them squeeze their knees together. Because if you have both, if that also reproduces pain, there's a syndrome called, what's it called? Hockey goalie baseball pitcher syndrome, or maybe those
Hmm.
terms are reversed. But there was actually an article in radiology, the Radiology Journal, that talks all about it, and it's got all kinds of images and stuff like that. And that's a situation where the split is a vertical split that goes down through the pubic articulation between the two muscles. I had a trainer at the gym that I used to work at that actually had that, and so we ended up having to get him to go see an orthopedist, and they ended up doing a suture job on it. So it depends on obviously what the patient's scenario is, right? If they're an athlete, they're more likely to have something like that. It's kind of more similar to like a sports hernia sort of deal um, than anything else. But that's something that I'll always check for because that to me suggests more of a musculotendinous or contractile unit lesion. It's not that it can't be driven or affected by anominate position relative to the sacrum and hip issues and things that and lumbar tone problems and all that sort of stuff that we've already kind of mentioned. Um, but at that point, you have to be able to figure out how to deal with the damage to the contractile tissue, right? And so
Mhm.
that becomes a little more, I don't want to say complex, but it's definitely something that is going to take some attention.
Okay. Thank you very much. That was helpful.
No, no problem. Anything else you want to add there, Dave?
Yeah. And yeah, I'm not as familiar with that condition. I'll have to take a look at that.
It's an interesting one. I might have the terms back, or it might be baseball pitcher, hockey goalie, or hockey goalie, baseball
Hmm.
pitcher. I don't know. It's a hyphenated word. Um, but yeah, you can look it up with radiology, the Radiology Journal, and there's a pretty nice article. I used to have it on my iPad that I carried around with me. I,
Yeah. The radiology journals, like there's a few of them. There's like a radiopedia, which is pretty nice as far as just different conditions and describing what we'd see. And that's where it first came up the term of like the term micro instability for the hip. They were talking about radiology terms, which really described kind of that Shirley Sauerman, that Diane Lee, or what Gail described as the sublux tip, or that hip that becomes unstable. I mean, I've seen it more and more creeping up. They're talking about the micro instability of the hip, but that came out of radiology, matched it pretty well.
yeah, I
So
got it
yeah,
right
the
here.
radiology stuff is interesting to skim over when you have time.
Yeah, I just went in just real quick just then and just Googled it, and it's definitely a thing.
Mhm.
So it's there. Uh-oh, Courtney's chiming in. Yep. So Courtney mentioned anterpelvic tilt. Pubococcygeus can kind of do that sort of thing. Pubococcygeus actually, little trivia here, is synergistically linked to the transverse abdominis. So if you can't get adequate transverse abdominis recruitment, you're not going to get adequate pubococcygeus recruitment, or vice versa, right? So if you have hypertonicity of one, you're going to have hypertonicity of the other.
I was just gonna say, a lot of times with that, like, is it pubic bone pain that he has, Joey, or is it like, like more groin pain?
It's more groin pain. It's like just
Okay.
above his pubic bone.
Yeah, I would look at like the rectus firing pattern too to make sure that so like anything that attaches on that pubic bone. So I'll see a lot of like either hypertonicity of the rectus and hypotonicity of the transverse abdominals and pubococcygeus combination, or right vice versa. So like that anterior, and then if 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 pubococcygeus and transverse abdominis aren't firing properly, you'll have adductor over tension trying to stabilize the pubic bone. Does that make sense?
Yeah, it does. And his adductors are super tender and hypertonic as well.
That's good. I mean, it's interesting stuff to talk about, particularly going on with what we're going to be looking at, because when you look at the pelvic floor, so pubococcygeus included, right, is it wants to kind of anchor things down and hold things together. both side to side and forward to backward. And the transverse abdominis, when we get into the lumbar spine, we start looking at it, it creates stability from this direction, right? So kind of that horizontal plane, because it attaches to um, that thoracolumbar fascia overlying things, right? And so it kind of pulls things tight. And so it's not going to allow a lot of this kind of side to side mechanism that can happen in the lumbar spine. But it's interesting stuff, and it's always about. And Jerry, the thing you're going through right now is just you're like, okay, I kind of know where the pain is coming from. It looks like it's more of a groin issue, so lower abdominals, maybe upper portion of the adductors, that sort of thing. And you're chasing the etiology. What is it that I can do, that I can correct, or we can find here, that if we can change something here, can we unload this tissue to allow the tissue the adequate time to heal? And that's kind of the nature of what we want to do as manual therapists, right? Is we want to be able to look at these things and say, okay, here's the thing that's damaged, here's the thing that's creating pain. But why did that happen in the first place, right? So why is this thing, absorbing so much more force than it's supposed to, that it's starting to break down? And that's where it kind of takes us into things like, well, lumbar dysfunction potentially with a segmental facilitation affecting things, or maybe an ominous rotation, or some sort of pelvis dysfunction that's affecting kind of the balance, that adequate balance that we have to have around the pelvic bowl to have kind of normal transitional forces going across the pelvic floor, going across the abdominals, going across all those other muscles that attach to that portion of the pelvis, where you're looking at things like the rectus femoris, you're looking at things like the quadratus lumborum, some of the long thoracic paraspinals, the hamstrings, the adductors. It's just like, oh, there's so many things here that are attaching here. And how do we kind of differentiate what's causing the problem from what's just what's a symptom, right? So um hopefully we've given you some things to think about and some other things to look at. But this is kind of the nature of the game, right? Is when we run into these sort of things, we got to be able to work it backwards, right? Okay, this is the tissue that's damaged. Why is it damaged? What is it that they're doing that kind of maybe set this thing off. For instance, the syndrome that I was talking about, it's more of an athletic thing. Somebody that has a high likelihood of overuse or some sort of strain of the tissues for the adductors or the abdominals, right? Either rotational components or kind of this forced adduction of the hips. That's kind of the general mechanism that these things start to break down, right? So you take that and you say, okay, does that kind of fit the profile, or is this an insidious onset thing, somebody that just works in a grocery store and stocks shelves, and then is this the sort of thing that's kind of setting them off? But yeah, this is exactly what we want to be able to get you guys to do, is be able to use the examination processes that we're teaching you to kind of work backwards from this is what's broken, this is what's damaged, to this is what set that off in the first place, right? And so it's good stuff to talk about. All right. Anything else? Yeah, vasectomy. That's a good one. Anything else? Any other questions before I kind of roll off into my PowerPoint here? Nothing? Okay. Am I good to share here, Dave? I think, hopefully.
Maybe all set.
All right. You see my screen there?
Yes.
Yep. Okay. So this is just the slide we left off on last week. We went over a lot of this stuff during our last session when we were talking about some systemic conditions that can affect particularly the peripheral joints. So a lot of these are kind of a repeat thing, and they also will affect spinal joints and potentially the SI joints as well. So systemic inflammatory conditions, RA, AS, Reiter's syndrome. I think you'll probably more likely see that written as reactive arthritis at this stage. I just think naming wise, that's kind of what we're calling it nowadays. Apparently, Reiter was a Nazi. Um, Ulcerative colitis, same sort of idea. These top four here will very consistently have Additional symptoms that affect the eyes, the fascia of the hands and the feet. So it'll look a lot like plantar fasciitis, fasciosis, as well as some urinary issues. So urethritis will also occur. So we talk about conjunctivitis, urethritis, and fasciitis being a kind of a distinguishing triad of symptoms for those top four. They will tend to have additional symptoms that kind of come along with it. Reiter syndrome usually has some sort of reactive arthritis will usually have some sort of instigating factor here. I've told the story about the gal that I saw, um, the woman that I saw that had the elbow fracture and ended up with, adhesive capsulitis of the shoulder and then needing her hip replaced on the same side because she had this reactive systemic condition after a surgery and a fracture and then the subsequent surgery in the elbow. So that's something that you can look at there. Ankyspond tends to affect the thoracic spine very substantially. So it will tend to affect kind of the elasticity of the joints of the ribs, including the cartilage there. The HLA-B27 test, which is a um, blood test, is kind of the diagnostic mechanism that we use for that. Ulcerative colitis will also have kind of the hallmark stomach issues, problems with eating and whatnot. Psoriatic arthritis is a little different, doesn't necessarily always have kind of that triad that we deal with the other four here, but we'll also have psoriatic plaques. So that's something that's also relatively easy to pick up on. But those are all sort of some systemic things that we have to take into consideration when dealing with the pelvis or the lumbar spine. Um, Pathologically, so if we deal with tumors, that upper lumbar area is really what they call kind of the forbidden area of pain. It's not very common to have biomechanical dysfunctions of the upper lumbar region. L1, L2, L2, L3. It's just not very common, but it is the most common region for the body to develop bony metastasis. So it's one of those things where it's just like if you're having, say, what looks like radicular symptoms of those upper lumbar regions, L1, L2, maybe even L3, then you have to take into consideration the possibility that this is a slow-growing, space-occupying lesion and not necessarily a disc lesion, just because it's a much more stable portion of the spine, kind of that upper lumbar region as opposed to the lower lumbar region. Side of the buttock we've talked about previously. Basically what this is anything that's going to flex the hip will tend to reproduce our symptoms, right? So a loss of hip flexion, either with the knee bent or the knee straight, a loss of trunk flexion, which would also include a hinging, like hip hinging type of movement. We could have painful weakness or non-painful weakness of the hip extensors. It's a sign of the loss of protective mechanism of the hip itself. Gluteal atrophy and or swelling. The swelling, I think, is probably going to be a difficult thing for us to pick up on just because in most people, you'd hope at least that there's a significant amount of tissue there. So it's going to be hard to find the swelling, but atrophy certainly should be something if you're seeing a significant difference in the size of one glute compared to the other, that's something that we have to be aware of, particularly if we couple it with this loss of hip flexion, ability to flex the hip, and then also our empty end feel, right? So if we start bringing the hip up into a hip flexed position, whether it's with either with a straight leg or with the knee flexed, and we can't complete that movement because of reproduction of severe pain, that's that empty end feel. Again, I've seen it one time in my career, and it was with a woman who I probably told this story as well, had a hip replacement 8, 9, 10 months prior. And she's kind of this dull, achy, not very comfortable pain, and it was kind of slowly getting worse, getting progressively worse. And what ended up happening is she ended up having a sign of the buttock, had an empty end feel. It just got really painful as we started bringing the hip up into hip flexion. Couldn't do it with the leg straight, couldn't do it with the knee bent. It wasn't very comfortable. And what ended up happening is the plastic portion that they put on the acetabulum was faulty, and so it had a defect in it. And what it ended up doing is it ended up rusting out a portion of the metal femoral head that they had put in. And so she actually had blood poisoning from this metal prosthesis that was in there from hip replacement, right, from the arthroplasty. And so that was a situation where they had to go back in, and she was on antibiotics for weeks and weeks, and then ended up having to have the revision done of their hip replacement. So that's the only time I've ever seen a sign of the buttock, but it is out there, and so we do need to make sure that we know about that sort of stuff. Any other causes, it's usually going to be when we see a sign of the buttock, it's usually going to be something pretty sinister, some sort of abscess in the posterior hip, maybe an infectious sacroiliitis, things of that sort of nature that have just progressed to the point where it's really not very comfortable. Some sort of septic issue, things of that sort of things of that sort of nature. You ever seen one of those, Dave?
I have not.
No, not lucky enough to catch one.
No, no, because even sacral fractures aren't as, many times as irritable as that, or as hot
Yeah.
as that.
Yep, it kind of depends, right? So it's like I said, you find this sort of thing, your first thought is I need to know what's doing this before I even consider moving this patient around anymore. Because it could be a tumor. I mean, it could be a femoral head or femoral neck tumor, or an ischial tuberosity tumor, or something. It could be any number of things that you don't want to mess with, right? So you find this better to have a medical examination done than to kind of mess around with that. All right. So this is really what I wanted to get through today is the idea of primary lumbar pathology. Okay, so I look at this and I think of three major types of primary lumbar pathology. And so those are disc pathology, instability, and or what you would call segmental dysfunction. So that could also be lateral shifts, anterior shifts, neural arch deficits. You could have hypermobilities, you could have subluxed facet joints. All of these things kind of fall into that quote unquote segmental dysfunction umbrella. Okay. And then the last one is really stenosis. And again, I think I mentioned this last week. This is kind of if you go from top to bottom here, this tends to be a very common progression of problems. Somebody develops a disc pathology, they get a disc herniation in their 30s, right? And so it's not particularly well treated, or maybe treated at all in some cases. That eventually, as the disc starts to destabilize and break down, it will progress to an instability. All of a sudden, the disc is no longer tensioned well enough, and so now we have this additional play within the intersegmental space, and so that creates an instability. The instability over time will start to break down some of the other passive restraints. It's usually going to be the facet joints. It's going to be the facet joint capsules. It's going to be the long ligaments, things of that sort of nature. And so these things will start to fibrose. As they start to fibrose, they get thicker, they lay down scar tissue, and we start to get narrowing of the spaces in and around the foramen. And so that progresses eventually to a stenosis. I actually saw a patient at one point, he was in his mid 30s, runner. Not really a surprise there that it was a runner. She can mock me all day for giving runners a hard time, but runner, real consistent, was doing, 20 plus, 30 plus miles a week, depending on what his routine was going to be over the next few weeks. And came in with this just real bad, kind of achy pain, both, and particularly on his right side, if I remember right, but he had it on both sides. And it just very much looked like, the 65-year-old male that walks in the clinic that has stenosis, right? Kind of bent forward, preferred sitting down. Every time he went running, he got this kind of achy, throbby type of pain going down his legs, right side greater than left. And what I ended up noticing with him in his history was he had in his early 20s, he'd had a disc lesion. It was treated at the time, it was mostly treated with anti-inflammatories and things like that. But did have kind of this long progression of instability in the lower back, and then ended up having basically a scar tissue version of lateral stenosis, and it was bilateral. And the fortunate thing was it wasn't so thick, it wasn't so built up that we couldn't do anything about it, right? So what I did, and I'll show you guys how to do this during the course, but we kind of put him in a flexed position to open up the foraminal space. And then we do a kind of what looks like a simple gapping manipulation to open that foramen. And if you do it with enough care and you do it with in the right position and you have the right type of patient, like this is not something you're doing to a 65-year-old female or a 70-year-old male. But when you're doing it to a 30-year-old guy, you can kind of get away with this sort of thing where you're just trying to pull that thing open and break up that scar tissue by doing a gapping manipulation, and it worked wonderfully. Like literally, I treated it once with that, and then we did a couple of um, follow-up sessions with him where we were just doing kind of some flexion type mobilizations to help kind of prevent any further buildup of any um, scar tissue in that region. And then we got him onto a stability program to kind of say, okay, we've got to figure out a way to help stabilize this segment because it's this underlying instability that's creating all this scar tissue buildup. And he did great. I mean, within a month, he was back to doing um, his full load as far as running goes. All his volume was back up where it needed to be, and it worked fantastically for him. So you can kind of do that sort of thing. You kind of get a hold of patients like that at times. It's just it's really interesting when you kind of see some of the things that the body can do to itself, depending on how these things kind of progress going down. So I always do want to talk about this. I don't know if you guys can see this real well here on the bottom, but the terminology for disc pathology um, is not always consistent from one profession to the next, right? I think what we're most likely to get from a physician is we're going to likely get that prescription that says HNP L5S1, right? And it's gonna say herniated nucleus pulposus. It's always the way it comes to me, and that sort of stuff. But if we look at herniation, the terminology, it does imply that there is migration of nuclear material, right? This thing has moved. Hence the term herniation, right? So that's not always the case of what the patient's actually dealing with. We can have things like a protrusion where we just have some bulging of the annulus, or some of those fibers have probably undergone some stress, and so it's kind of just bulging outward, but it doesn't suggest necessarily the idea that they have a true herniation where that nuclear material has been affected. In general, the nuclear material of the lumbar segments, it has to be degraded typically by a chemotaxic event, right? And that means either significant swelling or blood has been introduced. Okay. And so one of the most common ways for that to happen is with an end plate fracture, right? So an end plate lesion releases blood from the vertebral spongiosa into the disc, and that chemotaxic event will tend to break down the nucleus to the point where now it's capable of this migration, right? It's not built like a jelly donut, like everybody's always told us in the past, right? Is this stuff, as soon as there's tearing of the annular fibers, is just going to go seeping out. That's not how it works. Unless that nucleus has already been broken down by some sort of chemotaxic event, it's not likely to herniate. So that does tend to suggest, what's going on if we do have a true herniation. Um, but there's more than one kind, so the external kind is where there is some rupturing or some tearing of the annular fibers and it's become externalized. Um, or we can have a contained herniation. Okay, a contained herniation can create some of the most significant back pain, but because it's contained, it's unlikely to produce peripheralized pain, right? So leg pain associated with that. Contained herniations and lateral segmental shifts, those two things, they go together like this, right? They are the only two differentials that you'll get for somebody that comes in with exceptionally severe low back pain, but no radicular pain associated with it, right? So for me, that's something where I'm saying, okay, if I have a contained herniation, I have somebody comes in and they're shifted off to their right side, and it's just like, okay, it looks like a disc lesion, but they're not getting radicular symptoms or lancinating type of symptoms into the leg. I have to think, okay, well, this could be a contained herniation, or it could be that they have a painful traumatic lateral shift, right? So it's done that, kind of gone side to side. Way more common problem than what you would ever even remotely imagine. The people that come in that say they threw their back out and they haven't been able to walk for 3 days, that's pretty likely what they've done is they've got one of these lateral shifts. Um, in general, physically speaking, a lateral shift of the lumbar segment should not be physically possible. It shouldn't be possible. It's too much structure that should prevent something from going side to side like that. So it suggests that there is already some instability in that segment, right? That this segment is already broken down to the point where it's now allowing this non-physiological movement. Um, and so you're going to have to take that into consideration if you find a lateral shift. And again, I'll talk much more about lateral shifts, how to diagnose them, how to treat them when we get to the on-site course with you guys. But it can be really significantly painful, right? And so those are the only two differentials that kind of pop up like that for me. Um, Doing a standing shift correction. Basically, I got a hand on one shoulder and a hand on the opposite iliac crest, and I try and correct that shift. If that increases the pain, if that makes the pain significantly worse, it's going to be a contained disc lesion. Plain and simple, the body does not want to put weight over the top of a herniation, even if it's a contained herniation. So if the shift reproduces or increases the patient's pain, it's very likely to be a contained disc herniation and not a lateral shift. Correcting a lateral shift in and of itself is relatively painless. So again, we'll talk much more about those as we get into the course. So what else do we have here? Prolapses, as far as terminology here with the disc lesions, does suggest that there's some tearing of the annular fibers, but doesn't have herniation associated with it. Extrusion will have herniation, so essentially the nucleus has moved and it's actually externalized itself, probably into the neural foramen. And sequestration is kind of the more significant version of that, where not only has it externalized itself, but now it's starting to travel up and down the vertebral canal and affecting multiple other structures. In most cases, these last two here, extrusion and sequestration, they're probably going to need surgery to correct that sort of thing, just because there's now these externalized components of the disk material itself. Okay. So again, terminology does matter for me in particular, but it should for you guys as well. But we're not real likely to get anything other than HNP from a physician as these things come in. That's just kind of the nature of how they write these things out. Anything you want to add there, Dave?
Yeah, actually, I was fishing up on Jim's presentation on this topic, which is pretty good. He follows along with it, so I'm gonna try and get that out to you guys because this is it's nice to know that all discs aren't, or all back pain isn't created equal, and how to classify these back pains. I think it may have been in the first module, but it'd be a good one to go back and revisit.
Yeah, I mean, essentially, the first module is kind of the prelude to this, right? We're dealing more of the advanced stuff in this
Yeah.
module, but what I kind of the next few slides here, the common posterolateral protrusion, the common disc PLP. I always look at this as kind of our level one version of a PLP. Not all of these fall, not all protrusions, not all disc lesions fall under this umbrella and have this sort of presentation, but this is kind of the common version of it. Like we always tend to say, the common things are the things you see the most often. So this is going to be more common than some of the more severe things that we'll see. But this is kind of what it looks like or presents as, right? So posture wise, when the patient walks in, they tend to have some sort of antalgic position. Usually they're going to be deviated away from the leg pain, right? So if I have left-sided posterior leg pain, I'm typically going to be deviated to my right. Again, it's my body's reaction to I have this disc lesion and putting body weight on it, right? The compressive force on top of that disc lesion hurts and it increases the hydrostatic pressure, so the inflammatory pressure, which tends to put more of that inflammatory pressure into the nerve and will then kind of shoot more pain down the leg, right? So that's kind of the typical for the posterior lateral version of this sort of thing. If we have what's considered a posterior medial protrusion, where the protrusion is medial to the nerve root, oftentimes will deviate toward the side of leg pain, right? Because it's still at that point now we're just trying to move the nerve root basically away from that protrusion, right? And so that's kind of a little bit of a caveat there. But with the common lateral protrusion, we're going to be deviated away. They don't want to sit down. Again, any flexion-based position of the spine is going to make it worse, and it's typically going to make the leg pain worse. And it's going to be difficult for them to weight bear on the affected limb, right? So again, if it's my left side, when I put my left foot down to bear my weight when I'm walking, I'm not going to like that again, because it's going to be kind of pushing me toward that protrusion on that side. Responses to active range of motion. I put these in red here because they're very important and they should never, ever, ever be misconstrued for segmental dysfunction, right? These two things should look like complete opposites, barring us having some sort of, real outlier on either one, right? So if we put them into flexion of the trunk, right? So bending forward at the lumbar spine, it should increase the leg pain. Okay. What we're doing with this is we're pulling the nerve root tight over the top of that protrusion. And so that irritated nerve tissue, that should reproduce lancinating leg pain. Okay. Again, if we're dealing with somebody that has radiculopathy going along with this. Extension, so moving them toward extension into lumbar extension, should increase local lower back pain. Okay. And this is from compressing that disc protrusion, right? We're coming down on that disc protrusion. It's irritated, it's inflamed. It's no different than if I, got a bruise on my forearm here and I press down on it. It hurts when you do that sort of thing, right? That doesn't feel very good because we're dealing with damaged tissue, and pressure on damaged tissue makes it feel worse. But that shouldn't, in theory, again, barring some sort of severity change or some sort of anomaly here, shouldn't increase the leg pain, right? If we have a significantly sized protrusion or an extrusion, a herniation, that sort of thing, where as we extend that position, we close down that space and there's significant amount of inflammation, there's a significant amount of tissue damage, so a prolapse, something like that, that's actually now compressing that space in the foramen, it can increase leg pain, right? But the common PLP will not. And that's a good sign for us because what that tells me is I can use extension to help me correct this problem over the long term. Okay. Less consistent with this sort of thing, but side bending away from the side of leg pain will tend to increase the leg pain. Again, it goes kind of along with the idea of flexion and pulling that nerve root over the top of that protrusion. If I side bend toward the leg pain, it will also tend to increase the lower back pain. Again, very consistent with the idea of extension. We're compressing that lesion, and so it should increase the localized lower back issue. Okay. Neurological exam. We can have, in most cases here with this sort of issue, positives for fatigable weakness in the myotomal pattern. Okay, so it has to follow that myotomal pattern, as well as a loss of sensation along the dermatome and some sort of diminishment of reflexes. Now, there is some scale here as far as how consistent that's going to be, right? If we don't have enough inflammation, potentially to cause that hydrostatic pressure, maybe this doesn't happen. If the disc lesion isn't big enough, maybe this doesn't happen. If the disc lesion is in a particular spot, maybe we only have sensory loss and not myotomal loss. Maybe we only have a motor palsy and not a sensory palsy. If we have both, we would expect the diminished reflexes, but if we don't have both, I would expect the reflexes to be relatively intact. So again, there's some play here with the neurological stuff. Slump testing, again, that's going to put them more towards a flexion position. Should be positive for an increase in leg pain. Straight leg raise, same sort of idea. It's the exact same test, basically, just in supine. Lesegway's test, I've never really done this in clinic. It's basically a side lying straight leg raise. Why we want to do it in side lying, I have no idea, but it is a documented test. And the PKF here is the prone knee flexion test. Again, it's a dural test, but we're testing basically L4 and above, because L4 is going to split between the posterior elements with the sciatic nerve and then also the anterior elements with the femoral nerve. Okay, so if we're dealing with something that's higher up in the lumbar spine, we're more likely going to need to look at the prone knee flexion test. And again, we'll show you what that looks like during the course versus doing a straight leg raise or a slump test. Okay, because we need to tension that femoral nerve mechanism to get some of those higher levels in the spine. And again, if you have a prone knee flexion test that's positive, you're basically crossing your fingers that it's L4, maybe L3, because if you're looking at, higher up the chain, L1, L2, that's not a good sign. If we have positive L1 or L2 dural tests, very, very likely to be some sort of slow developing, or maybe even rapidly developing, probably more likely rapidly developing space occupying lesion, right? Because slow developing space occupying lesions often don't present with positive dural tests because the tissue has time to adapt to it, and so it doesn't get irritated. But if it's a more quickly developing thing like a hematoma, for instance, something like that, or maybe even an aneurysm, something along those lines, that's more likely to develop a positive dural test, right? So particularly for that prone knee flexion test, because it's going to test those higher levels of the lumbar spine. If you have that, you're getting concerned about the potential for some sort of space occupier. Okay. Here's the reason in some of the functional anatomy of this issue, right? So a disc lesion, there are two paired what they call basovertebral veins they basically go around and they go into the vertebral body, right? The posterior longitudinal ligament overlies them, and then there's a fat pad that covers them up as well. The longitudinal ligament does not attach to the vertebral body. It attaches basically to the end plate and to the disc. And so what happens is when we bend forward at the waist, it tensions that ligament, and then the ligament will compress against the bone and essentially compress the basovertebral veins, right? And so what that means is that the blood flow cannot exit the vertebral body. So it increases the amount of kind of fluid pressure within the vertebral body itself. This is designed specifically to counteract the increase in pressure in the lumbar disc, right? As we bend forward, we increase pressure in the lumbar disc. We then have to match that increase in pressure through the vertebral body. Otherwise, we could damage the end plate as a result, right? And so what this will tend to do to us is if there's a problem there, meaning we can't match that pressure, or if we do increase that pressure of the vertebral body and there's, say, an end plate lesion, they'll increase the pain, right? So that's one of those things that we have to take into consideration. And kind of some of the other benefits to this are noted in some of the anatomy sections here. So as we get to that, nerve roots, typically they're very high. They sit very high in the foramen. So if the foramen is kind of chews into the pedicle of the superior vertebra, that nerve root's going to kind of come down right underneath that sort of thing. So usually that's a little high for the disc to kind of irritate that unless there's a significant inflammatory process. So typically what we'll look at is if we're at L5, and we're looking at the L5 nerve root exiting underneath there, a lot of times it'll be the L4 disc that actually irritates the L5 nerve root, right? As it kind of comes down across because of that angulation we talked about. So that's the case in most situations. It is possible for the nerve root to be irritated by the disc at the same level, but it would require a significant amount of inflammation or a significant amount of annular damage to kind of impact that tissue. Okay. Yeah, we talked about this. Discs in younger individuals tend to be worse as far as symptoms go because they have a higher content of the proteoglycans. And so it tends to increase the inflammatory reaction. And then hydrostatic pressure, so this is the inflammatory pressure within the dural sleeve, is one of the major reasons for having radiculopathy, and it's not just the idea of physical compression from the disc lesion itself, right? So it's not just here comes the disc and the disc is punching into that nerve. That's physical compressive pressure. A lot of times more it's this inflammatory pressure that's built up around that nerve root and into that dural sleeve. And so all of a sudden it's that hydrostatic pressure that causes a lot of radicular symptoms. Okay. Segmental dysfunction. Again, this really shouldn't be mistaken for a disc lesion because of how these things kind of they're kind of polar opposites as far as the reactions we get. So an obvious instability here, patient that has some breakdown of some of these segments. Posture can be very variable. They could be very braced. We sometimes will call these people butt clenchers, where they're really kind of trying to anchor down with something. It's kind of like what Dave was talking about earlier, about somebody kind of trying to stabilize with their hamstrings, things of that sort of nature. Or they may be hyperlordotic, meaning they're kind of sitting into that lordosis more so than what we would typically expect. Could have a lateral shift, oftentimes with no leg pain. And again, this is with an obvious instability. So this is that lateral shift that I was talking about previously, where it's kind of broken down. The intersegmental space is lax now, and all of a sudden this thing kind of able to shift side to side. It just puts an absolute ton of pressure on all the inert structures, the facet joints, the joint capsules, the ligaments, musculature, the periosteum. All these tissues are just like, they hate it, and they're always just microseconds away from breaking down or having something traumatic happen to them. So really bad with that. Now here we're looking at the response to active range of motion. This is really what's starkly different between this obvious instability and the posterolateral protrusion. Generally, these people dislike extension. They hate being an extension. It destabilizes the segment pretty notably, slackens off the posterior longitudinal ligament, the ligamentum flavum, the supraspinous ligament, slackens off all the longitudinal musculature. So all of these structures suddenly don't have enough tension on them to help produce adequate resting stability. So going into extension tends to make this thing real sloppy, and it's going to slide around in painful positions. Flexion, however, tends to be a position of relief. They say, yeah, if I'm up walking around all day, my back starts to kill me after 30 minutes or an hour or 2 hours, whatever it might be, time frame wise. But if I sit down for 20 minutes, I feel way better, right? That's a dead giveaway that this is more likely to be an instability than it is to be a posterolateral protrusion, right? That makes sense. Side bending can be very variable, depending on what structures are damaged, right? So if we have a lateral shift, you might be worse going to one side versus the other. Or if we have a facet joint lesion, it might be worse putting it towards extension than taking it toward flexion. So if I have a left-sided, facet joint lesion and I lean toward it, that might make it worse. If I lean away from it, it might make it better. So rotation usually is going to be painful in at least one direction, right? And so that, again, is going to be kind of that ability to stabilize rotation, because the lumbar spine in general, not designed to rotate. Okay. Neurological exam. Relatively speaking, our neurological exam, terminology-wise, again, thinking about the term neurological, it's going to be negative. We're not going to show up with any palsy, right? We're not likely to have either a sensory or a motor palsy, not likely to have any diminishment of reflexes. So realistically, what we're more likely to get as a positive is the neurophysiological exam, right? That's where we're going to start to develop this consistent speed-dependent weakness with unlikely to have significant sensory changes. We can have paresthesias associated with a segmental facilitation, but then increased reflexes, right? So here with our PLP, everything's going to go down. Weakness, myotomal pattern, fatigable weakness, loss of sensation, decreased sensation, diminished reflexes. We come here with the neurophysiological stuff, and we're looking at facilitation. Again, the term itself, facilitation, should be a giveaway here. Increased tone that creates a velocity-dependent weakness. Hypersensitivity to non-painful stimuli, right? So that could be our paresthesias, paresthetic changes, could be that just irritability to to touch or to pressure, that sort of stuff. And then increased reflexes, because the reflex arc is really going to be the thing that sets off our facilitation. Okay, so basically everything goes up here. Hypersensitive, not necessarily hyper-reflexic, but increased or brisk reflexes, and then that increased tone that affects that speed-dependent weakness. Okay, certainly can have referred pain into the limb. Usually this is going to be due to a sustained posture, so being in a standing position for too long, or some sort of repetitive movement like running, for instance. So those typically will be more likely to occur with the referenced pain. And again, referenced pain is it's going to be more that kind of dull, achy. It might have some sharpness to it from time to time, but it's not going to be instantaneous, right? Referred pain is not the same as radiating pain, right? Radiating pain occurs as soon as the trunk moves. Bang, I bend forward and zing. There's that lightning bolt down the back of my leg. I put myself into a compression position with my neck. Zing, there it goes. It's going down my arm. It's instantaneous, right? That's radiating pain. Referred pain tends to take repetitive stress or sustained postures to make that sort of thing happen. You lay on your stomach during the night, and all of a sudden you wake up with radiating pain, or not, sorry, not radiating pain, referred pain down the back of your leg. It took you, 6 to 8 hours of laying in that position for the pain to be referred down the leg, right? So tends to take repetitive stress in order for that referred pain to be reproduced. Okay, all kinds of list of things that might be, painful here. We've got facet, joint capsule, annular fibers, the ligaments themselves, the dura. The dura, again, I've said this before and I'll keep saying it, it's not a true neurological structure. It's a connective tissue. So the dura irritation cannot produce neurological pain, right? It has to be the nerve itself to produce neurological pain, but it can produce referred pain, right? Because it is a connective tissue. So it's definitely capable of doing that. The iliolumbar ligament, this is a very unique structure. It kind of begins life from an embryological standpoint as part of the multifidi at L2. So it has a reference into the L2 dermatome. So it's usually going to get kind of groin pain or maybe the anterior medial thigh. But it's very common to have an iliolumbar ligament issue or irritation with an L5 instability, maybe an L4 instability, right? There's a variance there between almost 100% of multifida of the iliolumbar ligaments attached to L5. But there's like a 60% version of this, maybe slightly lower than that attach to L4 as well. So those two are the only two segments that can produce that thing for us. Yeah, I'm out of time. Look at me go. I already talked too much.